Good morning. Thank you for the invitation. I always enjoy coming to this meeting and speaking. So I do have some disclosures that are listed here related to some consulting activities for some of the new agents I'll be referring to, as well as one related to measuring levels, which is a challenge because they're not yet available at most centers. So this is what I'll talk about in the next 25 minutes or so, a brief update on what we call the direct oral anticoagulants, which is kind of the more accepted name than new oral anticoagulants because they're not so new anymore. We'll talk about reversal of Dabigatran, given that there is now an FDA-approved reversal agent, idarosizumab, otherwise known as Praxbind, and the study that got it approved, the REVERSE-AD study, and really then what is the algorithm for dealing with major bleeding with Dabigatran now that we have this agent. Then I'll talk about the 10A inhibitors, rivaroxaban, apixaban, edoxaban, and the coming of a specific reversal agent, Antagonists, but it's not yet FDA approved, but many think it will be this year. And finally, some comments about the challenges in really using reversal agents for major life-threatening bleeding. So just to really review the reversal agents for the drugs we're talking about, we have now on the available 4 oral, direct oral anticoagulants. 1 directly inhibits thrombin, Dabigatran, Nextolate, and 3 directly inhibit factor 10A, but they're all small molecules. Of course, they have a lot of pharmacological properties which differentiate them from warfarin or the vitamin K antagonists that make them very attractive, very rapid onset of action after you take them orally, fixed dosing for most indications irrespective of body weight and other patient characteristics, no effective diet, few drug interactions, but there are a couple. No monitoring required, shorter half-life than warfarin. But one of the challenges that these drugs don't have, of course, is a specific reversal agent up until now. So we don't yet have one for the 10A inhibitors, and we obviously now have one for Dabigatran. This is a very busy slide, really reviewing the pharmacological properties of the direct oral anticoagulants. I think it is relevant if you have a patient who comes in bleeding because particularly of the half-life issues with respect to the drugs, of how rapidly they will clear, particularly some of these drugs, but Dabigatran in particular is very heavily renally eliminated. You see it's got a half-life of 12 to 14 hours, 80% renal. So obviously the clinical situation will be quite different if the patient's creatinine is completely normal and they can get rid of the drug as opposed to having developed renal failure and coming in taking their drug. For the 10As, they're all about 1/3 renal, so it's still an issue, but perhaps a little bit less so. There's also some hepatic metabolism. There are some drug interactions mentioned at the bottom. One has to remember that the 10A inhibitors are all metabolized by the glycoprotein 3A4, and they're absorbed through the gut there's some action of P-glycoprotein, and inhibitors of either of those enzymes or inducers can affect drug levels. So there are a few drugs you need to keep an eye on, the azoles, the HIV drugs, rifampin, dilantin, Tegretol, St. John's wort. So it's important to look over the drug lists when you prescribe these just to make sure you don't have any major culprits. And if you have any questions, to do a cross-check through one of the computer programs that can analyze for drug interactions. I think it's just important to recognize where these drugs are approved. We've had a tendency to reach for an anticoagulant, being a heparin, low-molecular heparin, or warfarin for almost any thrombotic problem. But remember, these drugs now have all been specifically approved for specific indications, and this lists them where it stands right now. And this is going to stay this way for a little bit now. So hip replacement, knee replacement, rivaroxaban, apixaban. Dabigatran, interesting, just got approval late last year for hip replacement, stroke prevention, AF, all the drugs, and for VT treatment acutely, all drugs have indication. 3 of the drugs have approval for extended indication. DOACs should never be used in patients with prosthetic heart valves. One of the trials using Dabigatran at escalating doses failed, both with respect to more bleeding and more thrombosis on valves. So that's a place really where you should never use that drug. So I think one has to be very careful kind of doing things outside of the approved indications and be somewhat careful. I think, though, when you look at the totality of data with respect to the DOACs, in comparison to warfarin in the large trials that were done, the direct oral anticoagulants reduced major bleeding by 28%, and intracranial hemorrhage and fatal hemorrhage by 50%. And that intracranial hemorrhage is really a very robust and consistent finding. And even the major bleeding when you put the totality together. So I think an important issue with these drugs is that they're arguably safer than warfarin, which becomes an important issue in terms of this reversal issue, whether, how much important it is to have a reversal agent, or is the important thing to use a safer agent in the first place. So let's talk about the reversal agents. So the one that's been approved, of course, is for Dabigatran, and it only works for Dabigatran. It's iduricizumab. It's a humanized monoclonal antibody fragment indicated for patients treated with Dabigatran when reversal of the anticoagulant effects of Dabigatran is needed for emergency surgery, urgent procedures, life-threatening or uncontrolled bleeding. And it was approved by the FDA, and this comes directly from the product insert under accelerated approval last year, based on a reduction in unbound Dabigatran and normalization of coagulation parameters in healthy volunteers. So it's really approved based on PK/PD data, not clinical outcome data. Continued approval for this indication may be contingent upon the results of an ongoing cohort study, which I understand has been completed. So this is just the dosing of Dabigatran. It's in your slides. I won't spend a lot of time on it. You see that it's approved at 150 BID in the United States for creatinine clearance, 15 to 30. The FDA approved a 75 milligram BID, though nobody in the RELY trial was tested at that dose because nobody in the RELY trial got in with a creatinine clearance less than 30. So it's extrapolation that led to that dosing finding. VTE, it's got a lead-in with 5 to 10 days of low molecular heparin followed by Dabigatran. You cannot use Dabigatran straight out of the box. It wasn't studied that way. The dosing is 150 BID. And the total hip arthroplasty dosing is down below, which is shown there. So this is, iduricizumab is a humanized Fab fragment, binds with very high affinity to Dabigatran and its metabolites. The Fab is primarily renally excreted with relatively short initial half-life of 47 minutes, but a terminal half-life of about 10 hours. It has no interaction with other drugs and obviously worked well in preclinical models, and in humans resulted in immediate, complete, and sustained reversal of Dabigatran activity in normal volunteer studies. So this led to a cohort study in bleeding patients or patients who came in on Dabigatran who needed to go emergent surgery, published in England Journal last July, a 90-patient cohort study. There was no control group, and that's one of the issues I get sometimes asked. How do we gauge clinical outcomes? Well, to be honest, it really wasn't ethical to do a control group because there was no really established antidote. We were up here talking about PCCs and 7A, and there really was no clinical data in man that really worked. Yeah, it was great if you're a rat and you pump them full of high doses and cut off their tail and measure the amount of blood, but that wasn't real world data. So I think it was deemed ethical and appropriate to just do a cohort study given that you had really no established reversal agent. So there were two groups in this cohort study. One was people who came in with uncontrolled bleeding that was felt to be Dabigatran related, and the other group was a group that needed to go to emergency surgery or a procedure. Based on the data and the dosing, they gave a fixed dose to everybody of 5 grams iduricizumab. There were 2.5 gram vials that were immediately injected into the patient. And then they monitored PK/PD data across a period of 24 hours and also looked at clinical outcomes going forward. The target was 300 patients. They reported on the first 90, which I'll present, but I'm told that that full cohort has now been enrolled, and we should be hearing reporting. What are the endpoints? They're pharmacological. They're really blood tests measuring, really, measures of dabigatran activity in the blood, either something called the dilute thrombin time. This is not the typical thrombin time we order, which is highly sensitive to dabigatran. This is a modified dilute thrombin time that actually can quantify levels of dabigatran, and you can see the very nice linear curve you get. There's another test, the Eckerin clotting time, which could also be used to monitor, which is a little bit more sensitive to dilute thrombin time. But both are very good, and in fact, commercial assays are trying to develop dilute thrombin time. They're actually available in Europe to actually measure dabigatran concentrations specifically. So they did also look at cessation of clinical bleeding in Group A. That determination of bleeding obviously has to be done by the investigator, so it has some subjective component. And obviously during a procedure, the surgeon can tell you did they bleed or not bleed and how well was hemostasis controlled. And they also looked at a variety of other endpoints, mortality, when they could restart antithrombotic therapy and so forth. Here are the cohorts. You can see they're older patients. Largely AFib patients, median age, upper 70s, creatinine clearances, not totally normal, median creatinine clearances, if you will, 50s to 60s. An important issue is when you took your last dose of dabigatran, and if the patient can tell you, and you can see it's about 15 or 16 hours, and that's highly relevant in terms of trying to at least guesstimate how much drug is around. And you can see the number of patients who actually had abnormal laboratory parameters at baseline. There was no requirement to actually measure anything at baseline. You said, are you having a major bleed? When you take your last dabigatran dose, we'll give you the drug. These were all batched later on at a central laboratory, which was the primary endpoint of the study. So you can see that 40 or 51 had a dilute thrombin time at baseline. So 20% didn't even have measurable drug in their blood at the time they got it. So obviously these people were bleeding, but they were bleeding because they had a hole somewhere, which is one of the invariant things in anticoagulant bleeding. They're not bleeding everywhere. They're bleeding usually in one place because a vessel has burst. And that's important in terms of thinking about outcomes. Well, this is the efficacy data, the primary endpoint, the dilute thrombin time. And you see that immediately after giving it, you can see how nicely the dilute thrombin time and the Eckerin clotting time works. This is a very effective reversal agent. And you get sustained reversal over time in nearly all the patients, not everybody, but this goes out to 24 hours. So this is immediate acting reversal agent that works very effectively in terms of neutralizing the dabigatran in the blood. So this was a summary of the data. As I showed in the last slide, highly effective in neutralizing the drug. The median reversal within 4 hours, 100%, but the dilute thrombin time and Eckerin clotting time, evidence after the first vial even, but they did it with 2 vials just to be sure they covered everybody. You can see levels of normalization of both tests were 80, 90%, and similar results were seen with much less sensitive markers like APTT, which dabigatran can affect to a modest extent. So what about clinical outcomes? Group A was your major bleeding. Group B was your interventions. In Group A, the investigators determined the median time to bleeding cessation was 11 hours. Well, why 11 hours? Well, it actually takes time to figure out whether somebody stopped bleeding. We're not measuring, rate of change of hemoglobin, every 20 minutes or every hour. We get serial results every few hours, so you need to really have a little time to make an assessment. And that obviously for intracranial bleeding, you're totally dependent, actually, to be frank, about imaging, serial imaging, whether the bleeding has stopped. And obviously you can't do that very often. In major surgery, it's easier, and you can see that intraoperative hemostasis was achieved in nearly all the patients. 33 out of the 36 patients had what the surgeon said was normal hemostasis at surgery. What about safety? There was no hypersensitivity. There were some thrombotic events seen. Only one was early, within 72 hours. 4 were later. And remember, these people are high-risk patients for developing clots. That's why they're on Dabigatran in the first place. And, one of the critical issues is when you can safely reinitiate anticoagulation. And obviously, that's going to be an individual decision based on the extent of the bleed and the characteristics of the patient. And obviously, none of the 5 patients was receiving antithrombotic therapy when the events occurred. There were 18 deaths, 9 in each group, really which was related not to the bleed, but the presenting index comorbidity that primarily got them into trouble, emphasizing it's not just the drug, it's also the anatomic reason, and you get older patients, they have lots of comorbidity. So here's what I now write for the algorithm of dealing with major bleeding on Dabigatran: hold, discontinue the drug, supportive care, fluids, charcoal if they took their drug very recently, localize the bleeding site, obviously figure out where they're bleeding from, and then, of course, administer iduricizumab in life-threatening or uncontrolled bleeding for emergency surgery, urgent procedures if judged to have clinically significant plasma levels of Dabigatran. And there's no longer any reason, in my view, as a first go-to drug to consider for Dabigatran PCCs, activated PCCs, or 7A, or to employ dialysis. So let's turn to the 10A inhibitors. Here, the approach was different, developed by a biotech company in California, developing a recombinant factor 10 fragment of 44 kilodalton genetically engineered version of human 10A, which had its catalytic activity eliminated by the substitution of an active site, serine by alanine. So essentially, it's a decoy factor 10A variant that basically will sop up all of the 10A inhibitors. Interestingly, it'll work for apixaban, rivaroxaban, edoxaban, even work for heparin antithrombin, and also for fondaparinux. So it's an engineered fragment of factor 10. They've also knocked off some of the N-terminal residues. And it basically works by binding up the 10A inhibitor that's free in the blood and to pull it away, of course, from where it promotes clotting in the prothrombinase complex. So there have been studies with this recombinant factor 10 fragment in the New England Journal last November, I believe. They published a normal volunteer study where normal volunteers were even given apixaban for 3.5 days or rivaroxaban for 4 days, and then gave them this recombinant factor 10 fragment and followed their levels. And the dosing had to be somewhat different because, of course, apixaban is dosed a lower dose, BID, rivaroxaban, higher dosed once a day. So they had to give a higher dose of Anaxanet to the Riva group, 800 milligrams as a bolus, followed by constant infusion, followed by 400 milligram bolus. And that's something that distinguishes this drug from iduricizumab, that this drug has a very rapid half-life, much more rapid than iduricizumab. So they actually need to give that constant infusion to really get the levels down. And there you see for the 2 drugs, apixaban on the left panel, rivaroxaban on the right panel, what happens to the anti-10A levels. You can see that the bolus drops the levels down very promptly, but if you don't give the constant infusion shown in the lower panels, the levels start to edge back up due to the rapid clearance. So in fact, the protocol being used in the bleeding patient study is to give a bolus followed by a constant infusion over 2 hours. One of the challenges with these drugs, though, look at those curves after 6 hours, when the antidote or the reversal agent is worn off, that the levels of drugs are coming back up. And you see that in the control group that didn't get the reversal agent, they're sort of coming down together. So what's that all about? Obviously there's some reversibility of the drug coming off the reversal agent, and you're also sucking back drug from the extravascular space into the intravascular space. So it's, I think, a little bit of an issue with this, what you do after those first couple of hours for that first infusion. Obviously to get the bleeding to stop, but can you rebolus these people if they still need to get more drug? One of the challenges, obviously, right nowadays is we don't have assays widely available. All the assays are being batched, sent to central laboratory. There are assays being developed. The FDA has not yet approved them, in my view. The best assay, obviously, for Dabigatran will be something like the dilute thrombin time, and for the 10A inhibitors, something like an anti-10A level, but you'll need to use calibrators with rivaroxaban and apixaban. You can't just use your low molecular weight heparin calibrators that we can measure anti-10A levels with. There is one other molecule that's in development. It's a curious one. It's something called, can't even pronounce it, Seraparantag. It's a synthetic small cationic molecule that actually binds to Dabigatran and apixaban probably by cationic forces. You can read it here. We're not exactly sure how it works. It binds all these small molecules, and one of the real challenges it has is you can't, because of its characteristics, you can't measure blood levels when you draw blood into citrate, which we typically do for clotting tests, which makes it very challenging to get a regulatory pathway approval that the other drugs did, which was really a PK/PD pathway, where you really can't measure anti-10A levels, anti-2A levels, because of problems in measuring this small molecule. What it does, it binds to citrate and screws up the ability to monitor things. So they have to go back to things like whole blood clotting times to sort of assess whether this works. So I think it's got a more difficult regulatory pathway, although clearly a pill or something you just give IV to anybody on any anticoagulant is very attractive. So let me just close and make some sobering comments about the real challenges in reversal agents for major life-threatening bleeding in association with DOACs or for any drug, warfarin included. The clinical scenario dictates the therapeutic intervention required. Can supportive measures suffice, or invasive surgeries be delayed until the DOAC has cleared from the blood, rather than calling out the antidotes or the reversal agents to do it? Quantitative assays, as I've mentioned, are not widely available yet. If they are, how long does it take to really turn them around? Are we going to have 24/7? Turning around, probably not right away. Rapid point-of-care tests obviously would be helpful in guiding management. The worst outcome with an anticoagulant, of course, is intracerebral bleeding, but I think the challenges in improving outcomes there are great. You got to get somebody to a healthcare facility. You got to make the diagnosis promptly. You've got to give the reversal agent very early on to make a difference. One of the issues, will smaller hospitals stock these drugs given the frequency and cost of use? Major life-threatening bleeds on anticoagulation invariably occur at sites of anatomic lesions. The patient population tends to be elderly with comorbidities. These factors, in my view, rather than the ability to reverse the anticoagulant, often determine the clinical outcomes and mortality. So that's not to say that if I'm on Dabigatran and I walk outside on West Street and get run down and get taken over to one of the high tertiary care hospitals, tell them on Dabigatran I could talk and get the adagrasib into me, that'd be great. But it's another thing if I'm out in the woods and I have an intracerebral hemorrhage and it's going to take me hours to get to a community hospital. So the realities of dealing with these things are great. So these are my take-home points. DOACs are associated with a lower risk of major bleeding as compared to warfarin. There are two reversal agents to be aware of, adagrasib only for Dabigatran approved, and Daxonate is coming. And Daxonate's a factor 10A decoy protein that rapidly decreases anti-factor 10A levels and restores coagulation parameters. And further studies will be needed in real-world populations. And I think the clinical relevance in terms of outcomes really is yet to be determined. But obviously, this will be a valuable agents in our toolbox. Thanks very much.